Thompson. I am the Executive Director of the VHL Alliance. Josh Van is right here. He is our Director of Health, and on behalf of the leadership and the staff and the board of directors of VHL Alliance, we want to welcome you. Thank you for taking time out of your busy day, your busy weekend to join us and learn a little bit about VHL and build a little bit of reality. So a little bit of housekeeping. I think you guys noticed that the restrooms are in the back. Marta probably showed that to you as well. But you have some folders in there. If you need reimbursement for your parking, we just ask that you fill out that form and leave it with us today, and we can make sure that that reimbursement gets to you. Other housekeeping. Please help yourself to juice, water, goodies in the back. We need to get rid of it, so please partake in that if you would. I don't think we have any other housekeeping that I need to stress. Just wanted to do those two things. But what we're going to do today, if you'll indulge me, I'm going to spend a little bit of time talking about the VHL Alliance and what we do, and I'll hand it over to Dr. Cody, who's going to talk a little bit about the Hutchinson Cancer Center. And then we will launch into our panels. We have two panels today. First will be a clinical panel, moderated by Josh Mann. Have a whole question panel that we're going to roll with. If you have questions for yourself, I'm probably kind of put it closer. Is that better? Got it. Okay, so that's better. I will hold it close. So first is the clinical panel. We will have a break after that, and then we'll invite up our patient panel. And again, our aim today is connection. That's why it's called VHL Connect. We bring in VHL informed clinicians, we bring in family members to the area, and we want you to get to know each other and help us grow the family footprint in the Seattle area and in the state of Washington. So that's what we're aiming to do today. I'll tell you a little bit about myself. I've been with the Alliance for 3 years now, and I come by means of the U.S. Navy. So what I don't know about VHL and cancer is a lot. I spent about 10 years in the nonprofit space, and then have had the privilege and the honor to lead this organization for the past 3 years. It's been a steep learning curve, but I find it professionally the most rewarding thing I've ever done, to be able to serve our families and engage with brilliant clinicians and researchers so that we can optimize health outcomes for individuals that navigate each child and families that love them and take care. So that's a little bit about me. I want to give a little bit of plug about the VHL Alliance, a little bit of background. In 1993, when the VHL gene was discovered by our friends at the National Institutes of Health, right alongside that, the VHL Alliance was born by a spouse and a mother of individuals with VHL. And she was doing what many of you might have experienced, is wanting some answers. Had a lot of questions that weren't getting answered. Clinicians just weren't familiar with the condition, so they took it upon themselves to get that ball rolling. And unlike today, where we have resources in the palm of our hand, Joyce Graff had to go to medical research libraries and engage with clinicians and get the interest of researchers. And those efforts 30 years ago resulted in surveillance protocols that is widely utilized today around the world when it comes to VHL. So fast forward 30 years, today the Alliance has a staff of 8 all over the country, and we are the largest and only patient advocacy program supporting families with VHL in the country. We serve approximately 10,000 individuals in the country that navigate VHL, and that number will be important in a bit. I'll explain that. We estimate 200,000 worldwide, and we have very strong relationships both with the NIH and with sister patient organizations across the world, so that we can all support one another and individuals that have VHL. The Alliance, our purpose for existence is to serve patients, right? We are a patient advocacy organization. They're our primary population, and we support you through educational resources like the handbooks that we have published every year, which you can probably see on our resource table. We have educational webinars that everyone can participate in once a quarter. We have newsletters. We have research libraries online. We have, we want you to become empowered with education, and we want you to be the best self-advocates that you can. So we support you through educational programs. We also have wellness programs. We have online support groups. We offer one-to-one wellness coaching with coaching professionals. And of course, we want to connect you to the best clinical care that you possibly can receive, and I'll allude to that as well. So outside of the patient population, another primary purpose is research, right? We raise funds for research. In fact, the Alliance is the largest private funder of private VHL research in the world. Every year, we set aside at least $300,000 to award to researchers. And in fact, we're in research season right now. On Wednesday, our research council will come together and review 25 applications from researchers from across the world, and we'll award the top most promising projects. So we're very, very proud of that. We also hold in-person events that foster collaboration. This year, the International VHL Medical Symposium, which is an event that is hosted every other year, both internationally and in the U.S. This year, it's going to be in Boston in November. All of this information you can find on our website as well. And we're really, really proud of that medical symposium. It brings researchers and medical professionals from all over the world. We're expecting about 200 folks coming this year. And it's really, really one of my favorite things that we get to do. We also have a tumor board, a monthly virtual tumor board that we host that is available to any clinician that treats any VHL patient anywhere in the world. And we've had 2-3 dozen clinicians come every time. We'll have 2 to 3 cases that are presented so that clinicians can solicit feedback from experts from our clinical advisory council, or just present as an educational opportunity, right? So that is it's only for clinicians. We don't allow patients or industry into that session, so that it's a true clinical setting, so clinicians feel comfortable talking back and forth about those cases. So we're very, very proud of that event as well. And the third population that we like to serve are our clinicians, right? Those individuals that treat our families that navigate VHL. And one of the best things that the Alliance, I think, in my opinion, the best thing we do is our network of clinical care centers. Today, we recognize 41 clinical care centers across the country. And if you go to our website, you'll see our little map. You'll see that we have 41 pins. We'll see that there is a gaping hole in the Pacific Northwest, which is why we're here today. We are changing that network to be more than just clinical care centers. We want to add pins, something that a new tier of medical recognition called clinical partner. So if you are an oncologist in Billings, Montana, which we just had a meeting with last week, and you treat individuals with VHL in Billings, Montana, and in that region, we want to know who you are. We want you in our network, and we want to put a pin on the map. So our families, wherever they are in the country, are able to go not to a comprehensive clinical care center, but just someone locally that can talk to them in order to want to get off VHL care. So that's something that we're leaning into very, very much over the next couple of years. The last thing I wanted to end with was a really interesting and exciting initiative that the Alliance is entering into. So I mentioned that 10,000 Americans, we estimate, navigate VHL. And that's based upon an incidence rate of 1 in 36,000 births. So, since I've been with the Alliance, Josh and I both, we estimate that perhaps at most, the Alliance engages with about 2,500 individuals, whether through our clinical care network or if they're seen at NIH. We estimate about 1 in 4 individuals with VHL know who we are, right? So that begs the question, where are the other 7,500 folks, right? Do they know they have VHL? How are they getting their care? Do they know we exist to serve them? But that is a very hard thing to find out, right? For obvious reasons. So Josh Mann had a brilliant idea. He said that maybe if we access publicly available, de-identified patient claims data, it could give us a little bit of an idea. VHL does have an ICD-10 code, which only happened in the past few years. So we brought on we commissioned a medical data vendor who was able to get to that CMS data, which is not easy and not cheap. So, but we commissioned them to ask two questions. Number one, can you tell us in 2025 who, every individual that had a VHL claim, number one, and the clinicians who treat them, number two, the county and the state where they live. We asked that question, and for the first time, we now have a heat map. We have a very accurate heat map of where those individuals live in the country. And because this is a familial condition, you see hot spots, you see bright spots. And in the top 5 is King County, Washington, as far as the number of individuals with VHL. What is also glaring is Los Angeles County. Far and away, Southern California has the highest concentration of individuals with VHL. But even more interesting than that is we had a second query that we commissioned this organization to do. And that was, we want to know the ICD-10 codes of individuals that are likely undiagnosed with VHL. So there are certain clinical indicators that will prompt a clinician to be like, you might want to be genetically tested for VHL. So that includes bilateral renal cell carcinoma. That includes renal cell carcinoma and a CNS angioblastoma, or multiple hemangioblastoma. So under those 3 query conditions, we had that information pulled from the data, and a jaw-dropping 60,000 individuals came back. So, that just turns the incidence rate on its head. For decades, we've just been saying 10,000 Americans, 10,000 Americans. Even if that day that is 10% right, we're going to double the numbers of individuals that could have VHL. So that is even more exciting, right? So we now have our roadmap for the next 3 to 5 years of where we're going to go and who we're going to talk to. And we hope that it will help us get more people diagnosed, get more people empowered, get more people in front of VHL-informed clinicians, and save lives. It's really what we're in the business of doing. So that is the Alliance in a nutshell. And if you have any questions, I will be running around taking lots of pictures. Our website is chock full of information. Our staff is always looking to listen to you. So if you have any questions ever at all, you can call me, email me, come knock on my door. I'd be happy to assist you. That's why we're here. Okay, great. So I'm going to turn the microphone over to Dr. Scott Tycobi from the Fred Hutchinson Cancer Center, and he's going to tell you a little bit about the Fred Hutch and their interface with VHL.
Thank you, Janet. I'm excited to be here. I was so happy to be asked by VHL Alliance to join the program this morning. I really enjoy opportunities to interact with patients. We have a program for kidney cancer patients that's 10 years old now, where we have a summer symposium and trying to get people to come onto campus and interact with us. And some people are excited to come out and do campus tours. So we try and open the door, and we want to be accessible to our patient population. So I'm a medical oncologist. I've been at the Fred Hutch University of Washington campus since 2000 when I came out here. And my practice, I'm a clinical provider. I have my own patient panel. I'm also a clinical investigator. I do research trials. And my world is almost entirely kidney cancer. So kidney cancer patients in all forms, sporadic kidney cancer, syndromic patients, and then research trials for those patients. And so that's my experience. And I'm the oldest member of our clinical group, so I've been here the longest. So I'm the director of our kidney cancer research program for our clinical group. But I have 4 colleagues. There's 5 of us in medical oncology that see kidney cancer patients. I'm the person that really my entire practice is kidney cancer. My other colleagues, our clinical group is kidney cancer and melanoma, which is an interesting pairing. It harkens back to an older drug called interleukin-2 that's challenging to administer, and investigators gained experience with that and would link those 2 diseases together. And we've never broken them apart at our campus. Can I ask in the room, how many people are patients in the university system, and Fred Hutch system? So many of you have, personal experience with our campus, but just a couple of comments. So Fred Hutch and University of Washington is a combined entity. They merged, I think, 27 years ago, I believe, a couple of years before I came here was the formal merger of Fred Hutch and the University, and the mission of Fred Hutch, the name of that institution, was to be the focus of oncology care within the greater university medical system. So for UW Medicine, the oncology care is administratively supervised primarily by Fred Hutch, and the name on the building of the outpatient oncology service site, South Lake Union, is the Fred Hutch building. So sometimes a little bit confusing. Why are there these sort of two parties at the table? But it's one combined campus, but the oncology care flows through what gets labeled as the Fred Hutch portion of the greater university medicine program. And each member has its own footprint. University of Washington Medicine includes the Montlake campus, but also Northwest Hospital, Harborview Hospital. There's an Eastside Specialty Clinic site, and then Fred Hutch has affiliated sites, Overlake and Evergreen and Kirkland are considered Fred Hutch practice sites, Northwest Hospital. So each party has places you can go and still be cared under the umbrella of UW Medicine and Fred Hutch. As a medical oncologist, in years past, I had very little contact with VHL patients and other syndromic patients because we had nothing to offer. And patients that came to see me or had suffered a catastrophe, they had metastatic kidney cancer, which we don't want to happen. And many of those patients were being diagnosed with VHL in the setting of having been discovered to have metastatic cancer. And then as they were evaluated and worked out, lo and behold, they actually had a genetic predisposition that was not known. But seeing patients, much earlier in their course and trying to prevent them from progressing is a relatively brand new phenomenon. So belzutifan, the medication that we're now using and often prescribed for medical oncology, was FDA approved in 2021. So we're 5 years in to going from 0 drugs available for VHL patients to 1, which is a huge transition because now we're seeing VHL patients routinely in medical oncology. And so, not to dig too much in the weeds right now, but I think over the course of the morning and in the panel discussion, we can talk a little bit about what does that transition mean for the care we deliver, where patients are going to be seen, and what resources can we bring to the table to try and make the experience better for VHL and other syndromic patients. I think with Fred Hutch being more involved and more of a focus of a practice site for patients is going to be a great advantage because there are resources and programs that are embedded in the cancer program that I think we can take advantage of and try and do a better job in helping patients navigate a complicated medical environment where you need specialty care from a whole variety of medical specialists. I think before belzutifan, before a little bit more engagement with medical oncology, it's a disease that very much lives with the surgical specialists, so seeing urology, seeing neurosurgery, and also remembering to see ophthalmology, remembering to see maybe endocrinology. The patients I've seen coming into me, I'm always stunned by their list of specialists that they're already connected with and already working with. That's not the norm. So a patient that's newly diagnosed with cancer, usually, they need to see me, an oncologist, and that's their whole world. Now, I'm their primary provider. I'm going to navigate their care going forward, and if they need a specialist, I'll help them find them, but they'll come back to me, and we'll be the coordinating person in their care plan. And so meeting VHL patients that are thinking about belzutifan, but you've already had a whole life lived of managing the disease, and just the complexity that it inflicts on you is really, really noticeable from the care provider standpoint. And I think we can do a better job of helping people with that process. And, ideally, I think, becoming a recognized site for VHL care would certainly make a lot of sense for the Fred Hutch and for us to promote that. But, to have that mean something and that we actually have better resources and I think better integration across our campus. So that's our goal looking forward. We're in our infancy, I think, of really building out a better program that's more user-friendly to our patients. and something we'll be working on as we go forward the next couple of years. And again, I think some of those issues we can come back to as part of the panel, and questions that you have over the course of the morning, we're happy to try and address. So that's what I wanted to say just for an introduction. So again, I'm delighted to be here. And let me hand it back over to Janet to move us forward.
Thank you. Before we bring our clinical panel up, I just wanted to say a couple of thank yous. First and foremost to Slalom. We have Mike Heffernan over here, who graciously invited us to be in this space, which is just amazing. Thank you so much for that, and for Marta's help as well. We also want to thank our partners, Merck Pharmaceuticals and Ambry Genetics, that helped make this whole program, everywhere we go in the country, possible. So just wanted to give a shout out to our sponsors. And with that, I would love to introduce our clinical panel. Josh, if you want to come on up. Amy, Jack, Wendy, and Scott, if you come and take a seat up here, and Josh will introduce all four of you. Wait, what did I say? Amy? I'm sorry. Oh, that's okay. I probably should have put name tags on there.
Thank you, everyone, for coming. I think a big goal of this was, instead of doing the lecture style, which sometimes take a little bit long, hard to hang in there with, we decided to go with the panel format, which I think is going to be great, and also gives everybody an opportunity to ask questions there. But before we get into some questions, I just want to introduce the members of our panel. Dr. Scott Takodi, who you just met from Hutch, Dr. Wendy Raskin from W, Dr. Jack Brzezinski from Seattle Children's, and Vicki Yang, a social worker from Fred Hutch. So we're very excited to have them there. Maybe if we could just go down the line and really briefly, you can just tell a little bit about your specialty and practice and your relationship with yourself.
So, I am very bold. I am the oldest person in this room, I guarantee you. And I was the single coordinating center for VHL for many years.
Yes.
Prior to Scott taking care of patients with VHL. I was doing that forever because I, first of all, practiced in general internal medicine for quite a while, even though my specialty is medical genetics and I'm trained in medical genetics, but I wanted to see patients more than once. And so I ended up having a lot of patients in my clinic who had genetic disorders, VHL being one of them, but many other genetic disorders. And then eventually I moved over to the University of Washington Medical Genetics Division in internal medicine, and became the person who took care of complex, multi-system, cancer-related genetic disorders. And I followed patients since when they were teenagers, all the way to being adults and whole families. And I kind of because academics is a weird thing where people come and they take care of patients and they train and then they move to another academic center or somewhere else. And I kept track of the people in the different specialties who had some expertise in taking care of, if they saw more than one VHL case, that was the main thing. And I kind of was the coordinated person for them. And mostly I am what I call the person in the train station who sends people up to the right place. And this was before belzutifan, so things have changed a lot since belzutifan, and it makes a lot more sense now to have oncologists involved. But prior to that, there was really not a need for oncology so much as a need for surgery and ophthalmology and all the subspecialty things. And I knew the people I could send them to, so that's what I did. And now I partner with people like Scott and other people in, actually there are oncologists in neuro-oncology and others who do the belzutifan treatment, and I don't do it because I don't have that kind of a clinic. So I think having a coordinating center at Fred Hutch makes sense, but it needs to be coordinated with everybody because, in fact, the genetics is at the University of Washington currently. So that's me. I still plan to take care of patients for as long as I can, but at some point I will probably retire.
Sorry.
Thanks, Wendy. I'm Jack. I'm an oncologist at Seattle Children's. I'm the medical director of our cancer-free physician program, and my other hat is actually pediatric renal tumors, which are very rarely renal cell carcinoma. That is how I actually ended up in this game. It's originally at the time an adolescent with renal cell carcinoma showed up, they'd be like, "Oh, Jack, what do you think?" I'm like, "We should do genetic testing." And that ended up kind of getting into this field. I moved to Seattle just about a year and a half ago. Before that, I was in Mexico in Toronto, and I did all my training there, and then I was on junior faculty. I was on faculty, I was a junior faculty for 5 years. It's really in Toronto, Sick Disease Center that is very focused on cancer physician, and I learned a lot there, but I need to spread my wings because there are some kind of giants of care there that I need to go somewhere else to actually be able to pick up this field on my own. So I came to Seattle where there was very little pediatric cancer physician care. And now we are building up a clinic. We have some great resources. We have some myself on oncology. We have another oncologist, Dr. Chow. We have a nurse practitioner. We're going to get a second soon. We have coordinating nurse. We have social workers with us for all our patients. And very importantly, unique to pediatrics, we have a child-like worker that can help children deal with procedures, come to the hospital, having to play, health insurance with management of the child. I think the one major difference is that a lot of conditions like VHL and other similar conditions are often not diagnosed until adulthood. And so our clinic, instead of being a VHL specific clinic or being a specific clinic, just sees that we want to underpin to this condition. And then we end up having just very close connection to it. All the subspecialties, very close, finally genetics at this point, so a lot of diagnosis is going on. And then I thought say we actually have 2 genetic counselors that see the patients very frequently hands on. And that one in my profession has been some more genetics related and cancer related, but we start with that. So and hoping that we are going to grow and where we can serve everyone in a very comprehensive way. I think we're close to.
Hi everyone, I'm Vicky. I'm one of 3 elderly renal social workers at VHL. I also cover the sarcoma and hematology oncology clinic. And prior to coming to the Hutch, my first experience with VHL was actually in a GYN oncology clinic where we were doing, I think it was a cervical consult for somebody who had a complex situation. And prior to that, I didn't know about VHL that much. So I'm really honored to be a part of this team and to be able to send. I work on a greater umbrella of services called supportive care at VHL. And we have VHL Guide as well, which I adore. She is excellent, and she is somebody I refer a lot of families to, especially if they have children under 18 or children with developmental delays that are struggling with the parents' care or their own care. We also have psychologists and psychiatrists on staff who can help manage a variety of different medical, psychiatrically complex conditions. And yeah, I'm excited to be here.
These questions, I divided them up into categories, but I know that there's a lot of overlap. So if you want, feel free to jump in and answer your question. The first set of questions is more general, kind of specific to Seattle resources and care. Firstly, transitioning from pediatric care to adult care can be very complicated, jarring. How do your teams actively coordinate this transition?
Great question. Maybe Jack can pick it up. I'll start the first part, and then we'll move on to the adult caregivers. Yeah. So we really work to identify patients who are coming close to their transition, which for us is, we say, is after college age. And we are lucky actually at Seattle Children's, and we are allowed to look after patients until 30, but we rarely do, but we have that leeway to do it. So we start in high school, we start to give families and patients some heads up, you're going to transition soon, and it's time for
the teenager to start thinking of small parts of their care. And we work with social workers and child life to start thinking about what small parts of their own care can they look after. We build that up. When the patient is kind of nearing 18, we have a colleague at UW that we are starting to transition patients to, Dr. Lepig, and we start talking to her, and then depending on what surveillance that patient needs, we often will have a couple of years of overlap, which really helps the patients to do that transition. And this is not as prominent in VHL as, say, for example, Meigs syndrome, where they need breast screening, but breast screening is a great example of where at Seattle Children's, that's just one of the modalities we don't do very well. And so when patients reach an age where they need that, we will actually share care. What we'll do, a lot of the coordination at Seattle Children's, we'll send them to UW or Fred Hutch for their breast surveillance, and then slowly transition that care. And then, of course, there is a whole adolescent medicine team that really specializes in that. So for patients who look like they're going to have social difficulties in being independent, especially with complex social situations or families that are not cohesive, we get them involved early to help those patients.
So prior to recent times, I often saw cases with VHL and other complex disorders in my clinic, even when they were children, just to get them screened genetically. So I was able to get the genetic testing done quickly, very quickly, in fact, within a month of being notified there was someone who needed to be tested, which was much quicker than it could be anywhere else. But I'm not a pediatrician, so I couldn't take care of the children for anything other than their VHL-related things, just screening. Mostly because the parents who have an affected parent with an affected child, especially when traveling from far away, it was just easier to come to one place, so they came to me. Now we have a person who's the head of our medical genetics clinic at the university who's trained in pediatric genetics. She's actually a dysmorphology specialist and also a cytogeneticist, but she has training in clinical adult as well as children. And now a more coordinated transition program is being developed. So at the university, so it'll be the transition from the transition team at Children's, we'll send them to the transition team at the University of Washington. That's the plan.
So from the medical oncology perspective, if you don't have active cancer, you're not going to be transitioning to an oncologist to assume your care, or so these other modalities to help patients make their transition to adult care. However, there is at the Fred Hutch a high-risk cancer clinic for people that have a known genetic predisposition, and that is a service that can provide ongoing longitudinal care and help for people that just need surveillance but are not in any kind of active treatment. So there is the potential to find resources at the Fred Hutch campus that might be helpful for people that just need a surveillance management plan, or connecting or supporting a primary care doctor to execute that sort of plan. So there are resources beyond the medical oncologists themselves on our campus.
Dr. Raskin, you mentioned that working with patients outside of the Seattle area, this is for anybody, you have to bring it up. If a patient lives outside the immediate Seattle area, how can they best utilize the expertise at the local centers, either through telehealth or coordination with the local care?
I usually try to partner with I have patients all over the state, and I used to, during COVID, I had patients all over the WWAMI program, the whole WWAMI program, Washington, Alaska, Montana, Idaho. And I tried to find their primary care physician and partner with them to get at least the scans done and the blood draws done. And I still do telemedicine, and we do telemedicine in all our sites to make it easier. But of course, when people need to be seen physically, then we bring them in. And actually, it's much better if people have their scans done in Seattle, because we get to be able to see the results much more quickly, and they know what they're looking for. But actually in Bellingham, I have a group up there that I have, and they do as good a job. They do a very good job there too, so people don't have to travel down. When I-5 is blocked by an avalanche today from there. So that kind of thing can happen. So I think that with the availability of being able to do telemedicine as well as in-person cases in all three sites, there should not be a big problem with that.
Oh, just the other little thing to add is that because there are fewer pediatric patients and fewer providers who are comfortable with managing cancer physician on the pediatric side, we do actually I almost have it, but many of us at Seattle Children's who are in subspecialty care have Alaska licenses, Montana licenses to actually be able to help with patients.
Actually, there's a person in our group at the university who is licensed in multiple places, but his main specialty is metabolic disorders. So he can, but he's a medical geneticist, so he can do the same thing.
What do you see as the most promising therapeutic strategies for VHL over the next 5 to 10 years?
Well, I think so. I'll interpret therapeutic strategies as not being surgical modalities, but medical modalities. So as we touched on a little bit in the intro, the transition from no medical therapies to belzutifan in 2021 has been a huge change. So we do have a modality that's available. One of my colleagues, Dr. Tashiki, and I reviewed some of the long-term follow-up data on the patients that were in the initial study that led to FDA approval that have been followed now for over 5 years on behalf of that clinical trial. And more than half the patients in that study were still taking belzutifan at greater than 5 years in that study. So it tells us that a subset of patients can tolerate the drug for long, long periods of time. So, that's now front and center. We're using it all the time in our clinic. I think what's exciting is that there are other drugs that are entering clinical trials that share similar biology. So might there be more than one choice for treating patients a few years down the road? So that's a real possibility as we move forward in time.
What are the big, there's no cure for VHL, although obviously therapies are becoming more advanced and effective. But what are the biggest scientific barriers preventing a cure for VHL today? And how are these barriers being confronted?
Well, what would a cure look like? So a genetic syndrome where you're missing a functional gene, it's absent. So could you somehow introduce a gene into a person's body and make it be expressed throughout your body? And the answer is no. We aren't close to be able to do that. In a laboratory, if you want to add a gene to a cell, that's quite straightforward. People do it all the time for laboratory experiments. But in a perfect setting of a controlled growth of cells in a laboratory, it's still imperfect. So if you experiment and 70 or 80% of your cells took up the gene you're trying to express, that would be excellent. That's great success. But trying to do that in a person's body and get it to cells all over the place in different tissues and different organs is really not feasible. So I don't think in our lifetime there's going to be a cure in the sense that the genetic abnormality will be corrected and solved. But can we do a better and better job of addressing the abnormalities it creates? And belzutifan being the beachhead of therapy that can be quite impactful. Will there be new drugs and better drugs? And so at some future point, will you be able to control the manifestations and not get medical illness because of the genetic abnormality in a much more successful way that hopefully doesn't cause a lot in the way of side effects or problems? So I think that's a real vision and changes that could happen in the next 5 to 10 years sort of perspective.
I think also that belzutifan is terrific, and it works in most people, but it doesn't work in everybody. So that's why there's ongoing trials on additional entities in the same pathway, that hypoxia-inducible factor pathway. And I think that there could also be modifier therapies that could be merged together with belzutifan or another type of medicine like that, that could modify the side effects because right now there are medicines that can be used to treat the anemia, say, and other things like that. But it could be that there are more specific, better tolerated everything that could be merged into a more multi-drug, but put together in one pill packet. And I want to just raise one issue. I know it may be further down on the list, but people all think about genetics being we can cure it by putting it in with this CRISPR-Cas system. So is it okay for me to just mention? So that has been done now, okay? There have been multiple in-person clinical things done with trying to correct a systemic disease. So the very first was a very bad thing. It was when in China, a physician decided to correct an embryo, a couple of embryos actually, and put in something ridiculous. It was a polymorphism essentially that protected against AIDS. Okay, so it was the place where on the cell where the virus attaches, they corrected in a cell line that problem, and then they got embryos and corrected it in the embryos. Okay, that was very bad. That's not allowed. It wasn't allowed then either, but that happened. Okay. The next thing is that there are, in the field of oncology, especially liquid oncology, so hematology, where you can actually do that both out of this body. You can have cells that you take from the person, correct their problem, especially if it's a single change, like sickle cell anemia, and you can put it back in that person. And of course, it's a transplant essentially, so they still have to be treated, and those things are dangerous, but it can cure. The next thing is trying to do it in the person themselves. So you can actually get a group of enzymes that are actually mostly bacterial enzymes that are set up, they were developed over evolutionary time as the immune system for the bacteria. When it gets invaded by a virus, it has to have a way to kill that virus, so it doesn't die itself. And we use those enzymes to correct DNA, because that's how the bacteria used it. So you can do that in the person by putting in that bunch of enzymes into one packet and get it into the person. But you have to get it to all the different organs, and in VHL that would be very difficult. They have done it with lipid nanoparticles for correcting liver disease. So that you may have read about this one case where very, very, very rare, I've never heard of it before, metabolic disorder, where they corrected the child's disease by putting in these particles that could then get to the liver and correct the liver cells there. But you have to do these things, the cells have to be dividing. And in the brain of people and spinal cord of people, things don't divide quickly. They do divide a little bit, but not enough. So you could maybe correct some things, but not everything. So I think we should, as I totally agree with Dr. Takoti, we should, sometimes we promise too much, especially in genetics in the old days when I was first training, we promised too much. And partly we did it because that's how we got money from the NIH. We promised we could find a gene and correct the gene. That was what went into every grant. And in fact, we can correct the gene, but in a mouse and not in a person. So that's kind of where we are now.
So touching on that a little bit, if you had unlimited funding, what VHL research project would you prioritize?
I love that question. Because anybody that's in an academic center that's doing research and writing grants, you're always hunting for a budget to run a project and the next thing. And what if somebody just wrote a check that you could do whatever you want? What would that look like? I think we've touched on it a little bit. I think accelerating the timeline to test new therapies, new drugs that would manipulate the VHL, the hypoxia pathway, and that might be better tolerated and more successful than belzutifan. Those will come along, but could you do it faster if you had an unlimited budget? I'm sure you could. I think one of the wishes for our own campus is just data collection. Can I tell you how many VHL patients are in my clinical panel? No, like I kind of know, but I don't have any place I can just go and look. It's not recorded what happens to patients. I mean, it's in each person's individual care chart, but that's not abstracted in any way that you can go and you can say how many VHL patients are being treated at Fred Hutch and what was their outcome and how many are on therapy and how many stopped. And like the clinical trial, those patients, they're monitored and they're measured and all the data is collected into a wonderful database and it's reported and you create, publications to describe exactly what you see. What about the real world experience? I mean, how close our own patient experience mirrors what's reported in the New England Journal belzutifan paper? We don't know. We could know. I mean, it's formally possible to get approval to do clinical data collection and then build a database and analyze that. But just the resources and the manpower to do that and create that are just not in place and don't exist. So new resources coming in, could we not have much better ability to analyze our own success, our own outcomes, people sitting here that are getting therapy and understand better in our own backyard, our own patients, our own experience, what's really happening, and how could we, intercede if we see trends of things that aren't going the way we want, what can we do better, how can we manipulate the system, how can we help patients better, how can we find a better drug. So we'd love to have that sort of resource and access that over time would improve things for everybody.
And I will say through the VHL Society has sponsored the monthly tumor board, which I personally find extremely helpful and very interesting, and actually led to a research project that the paper's been being reviewed for 3 months now. It's being reviewed, but we're hoping it will actually get published. I have learned about the cases where patients become resistant to belzutifan, or where they have an unusual bad outcome that we don't hear about any other way. And because there's no centralized way to have these things, it's hard to get case reports published, so they mostly don't get published, and we only hear about them when they get reported to somebody. It would sure be nice to know why did people have these outcomes, and there are ways to do that. And even things like the cancer came back, why did it come back? Well, at the NIH, and I think now at Harvard, are they doing it there too? I know that they are sequencing the genomes of the cancer cells when they have come back. So on people on belzutifan, so what got those cancer cells to be able to divide when we've already given the one drug we know works to suppress, it doesn't cure, but it does suppress. And then we might find some other targets for therapy. The ones that target, there's lots of antibody therapy. I'm not the expert on that. I would pass it on to the oncologist for that. But that is clearly a topic that could be helpful clinically. And genome sequencing in many cases is expensive. So although it's getting cheaper, it's still expensive. So that would be one thing I would put the money to.
I'll just say that there are a few things that are so I'm not drug development guys, I'm going to go in a different route, but there's a few things that we're working on as a pediatric field. And again, because cases are small, most of our projects are either national or multinational. And where we really have the barriers is that a lot of times it'll be us, oncologists, like going by hand, trying to do the administrative work of like IRB approvals and contracts and even the chart abstractions, and it's very, very slow. So where the money would actually go is to just hire people who are good to actually do a lot of the work we need to do. And what we're trying to do is, number one, set up a national database of patients who have any predisposition syndrome to understand more clearly what the risk of developing tumors in childhood is, what the outcomes are when people develop those. And then things like, belzutifan was not approved for children, and the trial limited it to children, people under 18. There is an ongoing trial to try to get it to patients who are younger. But people have used it. The only people who really publish it, as far as I know, are at UCLA, but we've used it, other people have used it. And so trying to find out things like that, belzutifan and VHL, how many people are using kids and what are the outcomes? And just getting the database together where we can get that. And then the other thing that I work a lot on is tumor epigenetics and how we can use those to do early detection with cell-free DNA. And we're a long way off, especially in syndromes where there's multiple tumor types, which all may look different when we look at genetics. So trying to push that forward so we can actually have detection, even possibly pre-imaging. And then what you do with that? Well, the answer is if people on the drug development side can make something that is much less toxic than belzutifan, that is feasible to take when you don't have any symptoms, then that might be a time to intervene before you actually develop symptoms. So I think that's another place we'd love to move forward.
What role can patients, families, and patient communities play in helping to advance VHL research?
Well, I think, programs like this, the VHL Alliance, I think, mobilizing a community to lobby for better resources, better access. Some of the comments you've already made, I think, in terms of the Hutch, the oncology engagement with VHL is really in its infancy. So can we not provide better resources, better information, better care coordination for patients going forward? So I think, the more we hear from our patients what they need, what they want, the more we can respond to that. The Hutch likes to think of itself as a patient-centric care organization and trying to, encourage patient engagement and trying to optimize problems that exist. So we want to hear, we're happy to hear what patients need and what they want from us.
So I'd say on an individual level for families with children and adolescents with VHL, it's really just trying to make sure that you know what that child needs and being able to provide it to them, which in the medical side means just making sure that you have you have all your appointments in place, but actually more importantly to make sure that it doesn't really interfere with that child's life, right? And that doesn't become part of that child's life. And this is part of one of the really hard parts of parenting a child with it's not really a chronic disease, but something that impacts them lifelong is trying to make sure that they still have a normal life and a normal development, are able to go to school, do their sports. It's something we really try to emphasize in our clinic. But at the same time being like, well, but you do have to go see the eye doctor and stay at school today, and you do have to go get an MRI, and really trying to balance that. And I think it's a really tough thing for parents to do. But if you can do it, that's probably the best thing you can do for your child with VHL. And then I'd say as a large group, and not to get too political, but most of the clinical and research funding we get is federal. And as much as everyone really appreciates the funding that comes from places like the VHL Alliance and other philanthropic organizations, it is really hard to make up for cuts in federal funding. So lobbying when there are cuts in federal funding, Medicaid cuts are very much going to hurt clinical care for everyone because hospitals get reimbursed on Medicaid, and NIH cuts are going to hurt research. So I think as a large lobbying organization, it's where a lot of
Thank you. I would add to this because we've seen telehealth visits be so valuable for patients, especially our patients coming from Eastern Washington, farther away. The fact is Medicare telehealth visits have been at risk of every year. We've had probably months at a time when patients were worried they would lose access to their providers. So anything individuals, families, as an organization on the broader scale we can do to support the continuation of policies that actually lower barrier to access, that's what I would recommend. And it's specifically for insurance because I work with a lot of families who are on Medicare and Medicaid. And for especially young adults who might have a disability as a result of their genetic predisposition, they will likely end up on Medicare earlier than people who are 65. So this affects everybody across the age span, not just folks who are older.
The Alliance is in this. We have, for the past 5 years, dipped our toe and jumped into the deep end as far as patient advocacy is concerned. We have a patient advocacy manager named Marissa Beasley, and we engage with people on the Hill to access that federal funding. And it's something you have to do year over year over year, and you need senators and you need congressmen to endorse you to have VHL as a topic and have a seat at the federal research funding table. it takes a lot of volunteers and patient voices from every single state. So we do have a card in our research table about how to become an advocate. Marissa Beasley will reach out to you. We would love to grab your voice. We would get you on a virtual call with your congressional representative or senator. And we're fighting very, very hard to get access to that. In fact, in 2025, we secured $7 million for VHL research, which is, for us, that's a game changer. Like you said, we're a drop in the bucket, and the money is with at the federal level, and we're working very hard to keep that seat at the table, but we can't do it without your voice.
Moving a little bit back towards the clinical side of the VHL. Maybe this is directed towards you, Dr. Raskin, but again, anyone feel free to jump in. Can you speak a little bit about the genotype-phenotype correlation in VHL? And does one's mutation impact their surveillance and care?
I'm going to answer no, and then I'll expand. There is a genotype-phenotype correlation, and this is true for almost everything except for things like sickle cell anemia, where it's a single change, a single nucleotide, that everybody has that exact same thing, and that's a recessive disorder. So for dominant disorders, there are things called penetrance, where people may they have the risk, which I always tell people when they test positive for VHL, you have the risk, you don't have the disease. And I try to keep people not thinking about being sick. It isn't being sick, it's having a risk. And once you have a risk, you're forewarned, so you're forearmed, is kind of what it is. But in any case, a long time ago, there were papers that were published that looked at the variation in families with different types of variants, pathogenic variants in the gene. So do you have a missense chain? Do you have a big deletion, which is very common in VHL, the whole gene deleted or part of the gene deleted? Or do you have a specific missense change, one amino acid change, that gives you a different disease type than the others? And for the most part, no, I'm going to say no. There is a disease called Shubash polycythemia. Okay, that's a recessive disorder. It's not really VHL, but it's in the same pathway, but it's recessive. That one clearly is a different disease with different variants. But they tried to develop the system with, VHL type 1, VHL type 2. Is it 2C? Is it 2B? It's the only one that really makes any difference at all is the 2C, which is mostly pheochromocytomas and paragangliomas, but they get retinal angiomas too. And I treat everybody basically the same. Because yes, some people have less likelihood to get a pheochromocytoma, but you're going to be screening for renal cancer anyway. You're going to look at the adrenal gland. It's easy to do a blood test for metanephrine levels, so I just do it on everybody. With the 2Cs, I relax the surveillance with respect to doing brain or spine. I do it maybe once, and then I wait a while to see what happens. And I've raised this issue at the board, and nobody really knows what to do with those exactly. But the other ones, it doesn't really matter if your risk is 40% or 10%. It's still a risk, and we're still going to use what we have at our disposal to look for those things. So.
How does clinical and psychosocial care differ for somebody who's a de novo or first and family patient as opposed to somebody who inherited sort of? Especially somebody who's diagnosed later in life.
Okay, I must say, I'm married to a psychiatrist, but I'm not a psychiatrist. Okay. But I am a psychologist a lot of the time in clinic, and not just for VHL, because I take care of a lot of people who their biggest concern about themselves is what's going to happen to their children. And I tell everybody, as a geneticist, we are all mutants, every one of us. There is no way we got 6 billion base pairs in that embryo, that first cell that's, that we're diploid. And all those billions of letters that we didn't get something that didn't get corrected. Most of the time, for at least what we know now, it didn't cause a big problem. But A lot of the time it does. And when we all walking around with a little chip in us, which tells our whole genome, we're going to wonder, did we really want that? Because we're going to learn things about ourselves that aren't disease, but a risk for disease. We're all going to need a psychologist and a social worker with us all the time. But we all have children. I mean, when we have children, we wish we could have the basketball player, the baseball player. We don't want the football player anymore, no, but we want the basketball and the baseball player. And we don't get to choose. We just give life. And so whatever you give, good and bad, there should be no guilt involved with that. But there always is, and there's always worry, and especially when it's children. And I just keep my mind open when I take care of patients like this. I'm a parent and a grandparent, and I know how I feel about my children. If you're a new mutation, you don't know, you don't have as much information about the disease, that's okay. You can learn that, and we take care of people that way too. But so it almost doesn't matter in that case if you've inherited or not. But once you have it and you're thinking about children, that's often the biggest problem for patients. So I try to defuse that. We all have that, and at least if we know what we're dealing with, we give the best care we can. But I pass it to you.
I was going to pass this to Jack, but and truly, I think that the difference, like was mentioned, was this a surprise to you, or was this something that you had already anticipated potentially having to live with? As in, a family member who has it, or your parents might have the genetic predisposition. And those are two very different emotional loads. And depending on the age that somebody is diagnosed, this is so individual. What I'm basically getting at is we got to see what the individual is actually needing. Where is the struggle? Are you not sleeping? Are you not eating? Are you overly worried? Do you already struggle with mental health and other conditions that might be exacerbated by this new knowledge? I'm going to recommend everybody get a therapist, but that's a lot easier said than done. It's, at least for the patients who are connected with the HUDGE, even if you're not in oncology treatment for any reason and you're on surveillance, social workers can see you 1 to 3 visits, and we can help you get connected to resources in the community. We can be that initial project manager to help you lay out, okay, bite-sized chunks. What are the first things that feel most urgent? What are the next things that can follow afterwards? And a lot of the times, I'll be honest, I see patients who are older, who are adults and not under 21. So I'm going to pass it to Jack for those.
Well, I'll just say that I don't see the big difference being between whether it's a de novo variant or a familial variant. I think we see more in what the family's life experience is and how they interpret that news for their child. We do mandate social worker consult for every new patient, so usually when we have a new patient, we have this very standard order. Go see the genetic counselor first. Usually they've seen them already for some pretest counseling, then they'll see them again. Then they see me, then they see a social worker, then they see a child life support person, and then they see a research coordinator. I think that what we find is that there's a lot of families who look on the surface like it's fine, that doesn't bother them. They're like, especially, VHL is not the best example, but there's another disease called MEN2A where they have a high risk of thyroid cancer. And for whatever reason, we see a lot of these parents are like, yeah, my thyroid got taken out when I was like 30, and my brother's thyroid got taken out when he was 30. It's fine. No, that's going to happen to my kid. And that's what they say at first. And then you delve into it, and there's often a lot of anxiety about it. And that's why I think it's really important to keep that in mind and have whatever psychological resources are available, which we're lucky to have at all 3 of our institutions on hand for the patients, and make sure they actually see them, whether you think you need it or not.
I just add one little extra thing, which is sometimes I see a patient because, and not only for VHL, it's happened with VHL as well, but it's happened with many of the other disorders where the child is diagnosed first and the parent doesn't know. And it's thought that it's a new mutation in the child, in fact, it's inherited from the parent. And then the parent finds out they have this, what they think is disease, but they aren't manifesting it yet. or maybe never will. And it creates a lot of problems. And that might be the most difficult one when that happens. I see those cases.
Just a quick comment for our campus. We've always had a mental health care program at Fred Hutch, but if you read the paper, you know that accessing mental health care resources is really daunting and not enough providers. And for many years, that system was overloaded and really struggled to see our patients that needed them. And we now, I think, have evolved into a wonderful approach where Vicki and her colleagues in social work are the front door to our mental health care across a spectrum of needs. And so it's really working extremely well. I'm very happy with it. We reach out to social work. They're the first encounter with patients. Can they solve the problem? Can they provide counseling in their own right? Or can they connect you with a psychiatrist or a psychologist? That is what you really need. But they're offloading some of the patients that would have gone straight to psychiatry or psychology and making sure that the patients seeing those providers really are getting maximum benefit and doing a lot of the counseling on their own. So I think it's a really wonderful program. And so just a shout out to Vicki, I'm glad she's available for today because I think it fills a real need in our greater oncology care spectrum.
A big point of anxiety for young people dealing with VHL is thinking about family planning. Can you please talk to us a little bit about what reproductive options are available and supported through UW?
There's two things. One is a high-risk OB clinic, which can take care of patients who themselves have VHL and are pregnant. And there are two people in that clinic who are trained in our program in genetics, so they're specialists in genetics as well as high-risk pregnancy. There's also the pre-implantation genetics and IVF clinic, also run through that same department. It's not at the hospital, separate from the hospital, but in one of the outpatient clinics, and that's very easy to refer people there. So it's all easy to do. And I might add one, there was another question on there which kind of feeds into this a little bit. It's something about the barriers to genetic testing. Is that okay if I just do that one? I have not experienced that, and it hardly ever happens at Children's, so they are way privileged over us. So somehow the powers that be in insurance cares about two things: children, pregnant women. If a person's pregnant, you can test them for almost anything. But if they're just a regular adult, forget it. You have to really argue. But I have never had my genetic testing orders not done for a person at risk for one of these complex genetic cancer-related traits. You just have to have the right wording in your notes, and it's going to be covered. And now there's so much when I first started doing this, genetic testing used to cost $10,000 for one gene. I mean, it was outrageously expensive, and now it is nothing like that. So, and a lot of the places will, in fact, cap the cost for genetic testing for cancer things. That happens both at Ambriana and Invitae. And so people can do a self-pay, which is a guaranteed low price at some of these places. And there's also cascade screening once you know the genetic variant, which is the family variant testing, which is free in the first 120 days after the first one was found. So you can, people are able to wrap their heads around wanting to get the genetic testing. It can be done very easily and for no cost. So I have not found that to be a problem.
Regarding the family planning piece, because I do see some young adults that come through the cancer clinic, and I think this applies for VHL families as well. IVF can be really expensive because a lot of insurance plans won't cover it, and there are very limited so this is where I tend to say, if you're at Fred Hutch, we would lean into patient navigation or community organizations like VHL Alliance to help get folks connected to reproductive grants that might be offsetting some of the costs. And I recognize there is a disparity here in inequity because people who primarily need sperm cryopreservation, it's like $300 versus IVF is up to 10 grand, even with a discount. And that's for one cycle of cryopreservation. And so that is the barrier I see the most, especially with young adults, because nobody has, very few people have 10 grand lying around.
Now just touching on VHL kidneys. Typically, we've always used the 3 centimeter rule as the gold standard for when to intervene. Does this still hold true? And how has belzutifan changed this approach?
So I'll be interested to see Wendy's perspective. My urology colleagues have told me that in the VHL cohort of patients, that there really is not a demonstrated incidence of metastatic spread for tumors less than 2.5 to 3 centimeters. So that's their safety net, that they feel like it's safe to let tumors progress to that size before intervening and applying partial nephrectomy or ablations. That's not so cleanly true in sporadic kidney tumors. I have patients that come see me that have, 2.5 centimeter tumor but are metastatic. So, but the genomic syndrome seems to perhaps operate a little bit differently. The belzutifan data in the study that was done, you had to have a kidney tumor less than 3 centimeter to be on that study. So everybody in that study had kidney tumors. And so, my practice is kidney tumors. I'm seeing a lot of patients referred from urology to come in and talk about belzutifan rather than proceeding on with a surgery or an ablation. But the drug works for all the manifestations of VHL. So applying it independent of having kidney tumors makes a lot of sense. And I think it's going to back up and be used earlier and earlier in the course of VHL, to stop problems from progressing to the point of bordering on needing a clinical intervention. I don't think there's a reason to wait until you're at the cusp of needing a surgery to think about applying belzutifan at this point in time. But in a sense, that was how the study was applied when it was first being looked at.
I would agree. I mean, there have been, I've seen patients with VHL who've had tumors of 6 or 8 centimeters who it didn't progress in. But you can't go by one patient and you can't go by, in my experience, because it's extremely biased. However, it is true that for most of I take care of a lot of different syndromes, paraganglioma syndrome, multiple ablation, you name it, Burtrose Bay, all of whom have various types of cancer. For the most part, in these inherited forms, the cancers are slow-growing, indolent, and very rare to metastasize. But this is exactly where I really want to have all those tumors that don't behave like that sequenced, so I know what it is that's different about that tumor than the one that behaved the way we wanted it to. The other thing, the 3 centimeter one was really very helpful prior to belzutifan. So trying to have patients not have a lot of visits, so they didn't go to the neurosurgeon, they didn't go to the urologist, they didn't go to the endocrinologist, they had to go to the ophthalmologist every year, but otherwise they didn't go to everybody else. They went there when I thought they were getting close to needing surgery, and then I could refer them. But now, because there's more ways of approaching the intervention, and there's belzutifan, of course, we want to know earlier, and we are going to refer to oncology to treat people earlier. But also, there is a big difference in the first tumor than there is for additional tumors. Because once that kidney has been manipulated, there are changes in the anatomy where you have to think about, will it be more difficult to get that tumor out, whichever method that urologist particularly wants to use, if I wait too long. So if the tumor anatomically is in a place where waiting is going to be a problem, that's true for the brain ones as well, by the way, then the size is not the important thing, it's the location. And also, how many are there? And is the person not tolerating belzutifan? That's another one. So, it has to be individualized, is what I would say.
Regarding VHL in general, are there any specific lifestyle factors that impact the development of VHL-related manifestations? And conversely, are there any proactive health measures that somebody could take to protect their remaining kidney function, let's say, over their lifetime?
No. Okay. You don't put people on protein-sparing diets when they're healthy, normal children. So I don't think you would do that unless the person had, in fact, a lot of renal disease where they need to be treated like any other renal patient, I would say. It's probably better not to live at the top of Machu Picchu. It's probably better not to be a submariner, but we don't have data really on that. And there are papers published where people have had disease form, especially pheochromocytomas or other things like that, where they've developed it living at high altitude. But they're, true and related, or true and unrelated. I can't answer that question because most of the cases are sporadic, right? Most renal cancer is not related to a complex disorder. Most pheochromocytomas, most paragangliomas, really rare, mostly not inherited. They're heritable, but because they've got changes in them, but they're not, in fact, going to be passed down because they're not germline. So I don't think there is, and I know a lot of people used to be worried about flying because the airplane used to be pressurized to something like 9,000 feet, but now it's pressurized to like 5,000 feet. And there's, of course, oxygen on board if anyone has a problem. This is more a problem with people who have vertical bay syndrome, who get pneumothoraces and also renal cancer. But for air flights, that's not a big deal, and people can go skiing, and people can do a scuba diving once in a while. It's just living at very high altitude is going to turn on that hypoxia invisible pathogen, and that's the only thing I can think of that's something to do.
Theoretically, that probably makes sense. But what I was going to say is that it's not specific to VHL, but for every patient who has a complex cancer risk, we use that opportunity to review general good health habits for the reason that they may not impact the VHL-related cancer, but if you get another malignancy on top of your VHL risk, that's going to be more complicated to treat. So it's a great time for us for older children, younger adolescents to really harp on their increased risk if they smoke or vape, which are the really big things we try to focus on. And then really not applicable to VHL, but we just tell everyone about sun safety. And we try, honestly, not to focus on diet because that tends to be more harmful than helpful when you try to talk about diet. But if we can reduce the number of teenagers who pick up vaping, smoking is not as popular now in kids, but if you reduce the number of pick up vaping and increase awareness about sun safety, it won't impact your VHL cancers, but it will impact your overall risk of cancer. And if you're already at risk of VHL, then you can really reduce the morbidity.
So let's talk for a second about scanxiety, which is something that's very, very common in the VHL community where patients are constantly having for scans. Do you have any practical coping strategies for dealing with anxiety surrounding either before going into scans or after waiting for the results?
That's a great big question.
First of all, I will answer it as a patient, okay? When you get to be old, you have a disease, no matter what you were born with, okay? So it doesn't matter. Anybody, even with huge amounts of medical knowledge, and even though you're you think you're not worried about it, after the scan, you say, wow, I must have been worried about that. That's how you feel. So I would say that's true for everybody, and it's not worth taking up benzodiazepine for me to do that because it's over once I hear about the results. With respect to scanxiety, I try to get the results back to the patient the minute I get the result, and I get the result right away. It comes to Epic, and I look at Epic every day, usually more than once a day. And so I just write a note to people telling them right away what the scan is, what the result is. But unrelated to just the worry about what's that scan going to show, I do have lots of patients who have claustrophobia. So for those patients, I do provide treatment, pre-treatment for that, and also people who have, reactions to the dye. I treat that as well, but otherwise, I'm going to pass it to the person.
I agree. As somebody who's done many MRIs myself and done a brain MRI, I didn't have claustrophobia going in. I had claustrophobia while I was in there. And I developed that experience. And I was like, oh, this is why it sucks. And this is, especially for younger adults, young children, if this is their first time going through a scan, that's going to be really, the unknown is going to be potentially a bigger piece in their mind than the once they're there. So for adults, what I've recommended, if this is the first scan they've ever had, they're like, I don't know how it's going to feel. I'm worried how I'm going to respond. I offer, information. Would you like to know what the machine looks like? Do you want to see a video of how it looks for somebody going through this? Or is that going to feed more worries in your mind? I actually have a list of things, but I can compare. It's at 3, and I'm nothing if not very specific. So I often will say, ask yourself, is this a worry, especially around scans, that I can do something about? Is it something are there tasks I can do to help ease the worry? And if indeed that's not the case, distraction. Distraction is a perfectly valid way of coping leading up to a scan that might feel, even if it's routine, might feel like your future in your life and what you expect the future to hold will hinge on it, right? So engage in activities of joy, engage in community, in anything that is positively feeding your life in the time period leading up to the scan. And usually, a lot of times I hear folks say, I'm okay after the scan, I feel relief, and I'm good for, if it's 3-month scans, if it's 6-month scans, I'm good until the month before, the week before, and then it just feels like I'm on eggshells, or however their anxiety might present. I recommend mindfulness and breathing exercises and trying to incorporate these in your life before the scan. It's very hard to do that if you're in the machine and the MRI sounds like a mix of a construction zone and, the old dial-up sound. It's a lot easier to incorporate if that's already something you practice outside of. And this can work for kids too, in some ways, if holding still is hard. And then I do say, if like claustrophobia, there are concerns about not being able to lie still in the scan due to anxiety. Talk with your medical provider. Let's see if there is a medication that could help for that acute fear or that acute moment just to get through the hour. And that way you don't have to come back and do another scan because the scan wasn't good enough. Oh yeah, and the last thing, speaking kind of to the epic situation, sometimes the scan results result before our patients talk to their oncologist. And I know it's really hard, but the thing that I tell folks, one of the best things not to do is not read your results before you talk to your medical provider. Because, yeah, those results sometimes, even for people who work in healthcare but are not medical providers, they may not actually mean what we think they mean.
What's even worse is the patients get the result of their genetic test before I have a chance to tell them anything. So it's a rule, a law, that patients have to get this information, but I let them know ahead of time. If they want to know, they can find out. If they don't want to know, they can also deny, say that they don't want that answer. And sometimes I don't mind if they look at the scan ahead if I do it, but I can tell you that I've recently, there's a radiologist who's been remarking on the arterial supply to the kidney a lot now, and it'll say, well, there's the dual, a single artery to the whatever, I can't remember the exact phrasing, but it sounds like they've reported something wrong, and it's the actual right thing that the person has. So I'm oftentimes telling people, don't, this is normal, or they'll say there's a cyst, and of course so many people have a cyst. They have one cyst, I'm not concerned about that one cyst, but it's just that kind of thing where an incidental finding somewhere in the body is reported on those scans, which is not what we're really looking for. So not in the kidney.
We're lucky at Seattle Children's, we have a policy that delays specifically imaging results, pathology results, and genetic results. So the 3 things that get delayed by 3 business days. And 3 business days is enough for us to actually pick up the results and call the patient with it. And then I'll say that just one thing, I think we've come to a good system, but it used to be that patients would get a MyChart message from their either the provider or from the nurse coordinator, if it was normal, and a phone call was normal. So it was like if if your phone rang, you knew that there was something wrong. So we've changed that approach now, and actually have generally been able to get the scans done within 1 or 2 days of the appointment coming up, so that we can actually have another person talk about the scans, and I think that's actually been able to relieve a lot of that.
Rich, touching on the caregiver experience, burnout is something that we hear about very, very frequently when dealing with VHL, this lifelong of between the scans and the treatments and just the anxiety surrounding the whole thing. What resources or strategies or support networks do you recommend for parents of people with VHL, and even their siblings?
So I think that this is a multifactorial piece, and it really depends on where the family is coming from, what their social context is. Do they have other family and community supporting them, or are they kind of on their own in a new city trying to figure this out? For example, especially around communication, I think and depending on the level of medical involvement, if it's surveillance and there is more predictable medical appointments, that might look different, like caregiver burnout might look very different in those moments. But if there's active treatment involved and there's cancer involved, communication can be exhausting for caregivers. You're constantly talking to different people, giving them updates, family members, friends, especially if you're parents. Everybody wants to know how your child is doing. I often will tell folks, encourage folks, consolidate your communication to either a platform online that you can send somebody a link and say, if you want to help, here's the meal train, here's what we need, here's our updates. We're going to put everything there, or delegate it to somebody else that you don't have to be the person everyone's going to repeat the mental load that takes up your time from caring for your loved one. Finding community if you don't have community, whether it's the VHL Alliance and their support groups, or through the Center for Chronic Illness has support groups as well for people who might be experiencing, or patients who might be experiencing chronic pain and other symptoms. Finding the community that resonates with you is going to be really important if these individuals, if families are the type that want to reach out. Not every family is going to want to have, again, different experiences. Not every family is going to want to have strangers knowing how they're feeling, or meeting people in groups might not be comfortable. And in that way, it's the tailored support, one-on-one. Let's see, can we get you connected with the social worker to at least get a sense of what's going to work for you and where are the gaps in caregiving that you're feeling, especially for parents. Something that I think about because I work with folks who are in their 40s and 50s often, and they have children who are just coming out of that high school into young adulthood, planning for the future. And this is not a fun or attractive topic to talk about, but if you know you might have a life-limiting illness, estate planning, if you have, if you have other responsibilities and you're worried about your child, guardianship planning, having those documents in place as part of advanced planning, I actually normalize it for all adults, not just like cancer patients and not just people with a genetic syndrome or a predisposition, because that's going to bring more relief, knowing that things are in place if a worst case scenario were to happen. And then in terms of burnout, respite care is often talked about, but also hard to conceptualize. And that, to be frank, depends on a community, depends on resources. For people on Medicaid, we could potentially get caregivers through the state-funded programs. But that's a very specific subset of folks. For folks who are kind of in between, that's where I find the challenge is. And that's often looking at community centers, looking at volunteer supports, and helping people get tapped into what resources might be available through the local networks that they live in, whether it's faith communities or otherwise. And for folks who have resources, normalizing that you can't be this one person or the two people for everything. Delegating, whether it be having in-home help for the chores that you can't get to, or having transportation help so that you can help just focus on your loved one and not have to try and figure out how to get to appointments. Those are all problem solving and feed in.
I think those are great answers. I don't have too much to add except to say, I think there's multiple layers of this question. I have not seen burnout specifically in patients who are just getting surveillance and don't have tumors from those parents. That doesn't seem to be that onerous on those parents. I mean, it's onerous, but not to the point where they're getting burnout. Where I see is with my patients who do have cancer. And unfortunately, I think that the risk factors for burnout are mostly ones that we as clinicians do not address. And it's usually how strong your community is, how much family support you have, and a really big thing for when we have like basically one major pediatric cancer center in the state is how far away do you live from it? And if you have to really uproot your life. So, patients in Central Washington will often have to uproot their lives and come live in Seattle for the course of a child's treatment. And we can provide the resources in terms of the place to live, and we can provide a little bit of respite care, but we can't, what we can't do is make up the income that they're losing, and we can't make up the fact that they're uprooted from their communities. And I don't have a good individual answer for that. I think, again, this is something that needs advocacy to build up a better network of possible so people don't have to get uprooted as much.
So I have just one final question for the panel before I'd like to just open it up to the end for questions from the audience. But what is one piece of advice or message that you think that every single VHL patient or caregiver sitting here today can go home with to better advocate for themselves and their loved ones get the best care possible?
Well, I think we've touched a little bit this morning on, the desire that our care network can be a better resource and more streamlined and more organized, but I think also, encouraging people to be self-advocates, to reach out if they have questions, to seek help or guidance or clarification. As I said, I'm always amazed at the complexity of the care people have already received that I'm seeing in my clinic, and it's a lot on your plate. But, being an advocate for yourself and interacting with the care environment, as all of us, I think, probably have, experience of being patients ourselves. It's eye-opening when you're on the other side and realize sometimes how inefficient and annoying the system can be, and you do have to push to get what you need at times.
I would just say that's exactly what I think.
I totally agree with that. I think the one other thing to keep in mind, which I think the VHL Alliance is doing a great job of, is that the people who tend to come to events like this and who are very involved in the VHL Alliance tend to also be the people who are really good at advocating for their own care and for their family's care. And what I worry about are the patients who are not at these events, and the ones who, the 7,500 that we alluded to that aren't really like hooked up to the VHL Alliance. As they're often the ones who need the most support and don't know how to access it or don't have the wherewithal to access it. And so I would say as I want to just applaud the work the VHL Alliance is doing to try to find those patients and help them out with resources. And I think that is going to make a really big difference to how people can advocate for themselves.
And as a therapist, I'm going to go back to the individual and the families and ask that everyone continue to live life in the meaningful ways that are important to you, because yes, this is a really significant part of people's lives, and there's so much more than just VHL. And so a lot of what I do with patients who have terminal cancer is I encourage folks to continue to find the meaning in life, in those moments that help you feel connected, in those activities that bring you joy, because at the end of the day, all of this is so that we can live well. And that's the one thing I always tell folks to, like, if it's hard to focus on anything else, focusing on, okay, what are the things that are important right now in my life outside of my health care?
Thank you. So we have about 20 minutes left. I want to open it up to questions from the audience. If you want to raise your hand.
So I have HLRCC syndrome, and a thank the VHL Alliance for allowing me to come. One of the questions we struggle with is if we also have a 50% chance of passing it on to our children. And the question is should we get our children tested? And there's a lot of cons against it. Just wondering what your position is. Should we get our children genetically tested early?
Okay, well, I see a lot of people with HLRCC, of course. So, first of all, the rule of thumb in medical genetics was you don't test a child. I mean, this is you don't. It wasn't we asked people. We were taught you don't test a child unless there was something you could do until they reached the age of majority, which was 18 to 20, the way it was. And that way they were involved in making the decision as to whether they want to be tested or not. But that has changed because, of course, things now are available for treatment for many of these things, and certainly for surveillance, and also there are early onset. So in general, we try to tailor the time of testing to when there is going to be the chance of manifesting the disease. So let that kid be normal and not go to the doctor. The parent may worry, but the child can just be a child for a while until it's time when you would start doing some kind of surveillance. And that is, of course, a moving target too, because there's always the first case. So that 7-year-old who had, died of metastatic cancer with whatever syndrome you look at, even though that's extremely rare. We don't know what the denominator is. We only know that's the only case that was published. But we kind of use that number and then the average age at which something is found. And that's what I would say. So the other thing is, if there's a treatment, that's a different story. Right now we have a treatment. Even though it's not approved for children, it's being used in children. I know that from the tumor board meetings. And I also know it's being used even, this is just a total aside, unrelated to this, but if I don't say it, I'll forget it. It's contraindicated in pregnancy, and all the testing of rats or whatever else shows that it caused decrease in sperm counts or who knows what else. It has not been shown to be the case in people, and there have been people who have been pregnant and had babies, and nothing has happened with that on the belzutifan. And the same with male fertility. We just don't see that yet. But there's no coordinated center keeping track of that. We don't know what the denominator is. We don't know how many people have tried it. So that is it. But I would say with respect to testing in children, it's a combination of would you do something different if you knew? That's one. If there's something good to do, and how comfortable are the parents as well as the child? Sorry, so it's a combination of it's a joint decision.
I'll just say for HLRCC in particular, and for those in the audience who aren't aware of it, it stands for hereditary leiomyomatosis and RCC. And so there's definitely a connection. But the difference between that syndrome and VHL is that tumors become metastatic quite early on in their development, and when they're small, which is a big difference from VHL. My personally youngest case of a patient with HLRCC developed an RCC was 15. And I know that there in the literature it's even younger. Yeah. So our recommendation right now is for that syndrome, particularly to start MRIs at 10. And we can talk more offline, but because there is that opportunity to actually catch tumors earlier and intervene on them, for HLRCC is actually one of the conditions where I do strongly recommend testing before the child comes in.
You don't even have the long-term information, even anecdotal, because it wasn't available, only from the start of the trial. So we know that people have been on it for a very long time. We know also that the dose can be, in some people, reduced. So instead of 120, 80. I know from the tumor board, there's at least one person who's been on 40 for a long time, and that seems to be holding things at bay. There have been people who have been started and stopped, and that has worked, although this is, it bothers me a little bit, only because the body is so good at finding ways to get rid of things that are foreign to it, and it can mutate to make it not respond, but we haven't seen that happen. So there's been starting and stopping, and that seemed to work. Starting and stopping with respect to some side effects, they mostly come back again, so that wasn't a good cure. Because there was a case, and I'll only mention it like this because actually it involves him, I think, a case of a person who was going to be on for some number of weeks and then off for a week. Is that you or somebody else? I can't remember.
We're not done that.
Okay, good. Well, I asked that tumor board about that, and Dr. Iliopoulos, who ran the trial at, he's at Harvard, and he runs along with Josh, runs this tumor board. He is trying that as well and seems to think that that works, but we really don't. We have anecdotal information. We don't know if there's going to be resistance to the medication if you stop it and then start it again. I doubt it would happen with stopping short term and starting again. It's really, and I think of infectious diseases where you don't want to do that with tuberculosis, things where bacteria is going to get what's in you is going to learn how to fight that antibiotic, and now you can't be treated. So it would be great to have these national registries where we know what people have tried, even if they're case of one, that's okay. The more we gather the information, the better we're going to be at knowing how to manage these things.
Well, as somebody that, prescribes belzutifan and follows patients, it's a great question. When you look at the study with VHL patients, very, very few patients that stopped the drug in the study. It was because of emerging resistance to belzutifan. I think there were a couple, but most patients that stopped appear either electively decided it just wasn't worth it, or they were having bad side effects, they felt poorly, and they came off the drug. We have a lot of drugs in oncology that are supposed to be taken every day, and their pragmatism rules the day. People develop side effects, you have them take a break on therapy. For advanced cancer, you don't want them off the drug too long, so usually you're doing short breaks of a week or two to let side effects get better. You start it again and you go on, off, and you come up with this customized recipe that doesn't truly follow the product guidance, but it just works well, and that's what you do. I think for belzutifan, again, more than half the patients took the drug for 5 years on the study. You have this horizon that you don't know how long you be on this drug, 5 years, 10 years, 20 years, the rest of your life. And what if you don't feel normal and, every day you're a little bit tired and you have some annoying side effects, for a week, it's no big deal, for a month, for a year, for a couple of years. But at some point, do you think, I'm not sure it's worth it anymore to keep on this drug? So I can guarantee you, over time, we're going to have patients where we say, look, your scans look great, you've had some shrinkage, everything's stable. Let's stop, and let's just watch scans, and then in 6 months or a year or 2 years, if things are growing back, we'll go back on again. So I guarantee you that's going to happen, and we're going to do that in the clinic for patients. Haven't had that conversation yet, but I'm confident it's going to happen because of the success of the drug, and the horizon is so long. So if you're having side effects, why can't we take breaks and use it intermittently to still get benefit, but have these wonderful holidays where you're off drug and you're feeling better?
I guess I want to bring it kind of full circle. One of the things that I heard earlier were funding, NIH funding in particular. If you have the option of receiving a blank check, so how can we, as patients, be better advocates for you in reaching out to funders? And the second part to that question, if you receive a check, not a blank check, but a check, what amount might that be where it would enable you to create that registry that we have listed?
When you think about, this is actually was a barrier to me when I was asked many, many years ago to create a VHL center. I was me with nobody else. I was me who was basically funded by the NIH over my whole career, doing research not on VHL, on other inherited disorders, mostly neurological. But it is very expensive to manage, even when it's just a registry, because you need a person. The minute you need a person full-time to do something, you're paying not only their salary, but their benefits. So whatever the salary is, it's 1.3 when you multiply it up. And it ends up being a very large amount of money very quickly. So, and then just the computer, managing the computer and managing the communications with everybody, it's usually more than one person. So grants are often in the $500,000 range. That's the usual typical one-year grant amount. So when you write a grant to NIH and it's for 5 years, you're asking for $2.5 million. And even that's not enough to run away. So for lab research, which is what I did, I did molecular biology, so I'm not aware. I don't do clinical trials. I have to pass that on to other people. Also expensive because you need people who do the coordination and the intake and the reaching out to patients and the patient safety stuff and all of that. All of it is extremely expensive. So it's very difficult for a small organization like VHL because it's a single thing. The Ataxia Foundation, the National Ataxia Foundation, which has funded my research in the past, they're much bigger because they cover a much broader number of diseases, both inherited and not, but they cover them all. And they're able to give bigger grants, which end up to be, preliminary data for writing for a bigger grant. But if you can advocate to your representative in Congress, we need, it's a desperate need to have more data collected on patients with VHL and other disorders that might, lots of other diseases feed into this hypoxia-inducible pathway, by the way. So there's many. There's, not only, there's a whole bunch of them. Everything related to renal cancer fits into this. Lots of metabolic disorders fit into this. So there's a way maybe to partner with other groups to lobby, badger the representatives because they get a pet project and then they're going to get the NIH to say, now we're going to cover Alzheimer's disease. That's the biggie that did it. Or now we're going to cover this other rare disease because some member of Congress has a relative who's got that disease. That really happens. That's exactly what happens. So the more noisy you can be, the better it is. But I think that if any amount of money that could be given, it has to be coordinated to set up something in a place that's set up to do this nationwide, but also internationally, because we as a country don't do well with registries. So in Europe, we get tons of information about the people who have disorders because they're collected. They have a national health insurance in almost all of the developed countries, except us. So we can partner with people in other countries to do this as well. And I think the tumor board is a good example of that. People zoom in the middle of the night from Vietnam, from the Netherlands, from South America, from places where they oftentimes don't have a coordinated way to take care of VHL. But if we can get all of those people involved, we could really get a lot of data. And I can't tell you, maybe you know more about what it would us to coordinate something like this.
Well, I think, if you wanted to create something in your own backyard, like at the Fred Hutch, to sponsor a person, that would be a full-time data coordinator that would be responsible for collecting VHL clinical data on our campus. You're looking at, in round numbers, $100,000 per year to support that person as a philanthropic gift. So it's a tall order. To say, a perspective bigger than just a single cancer center, if you facilitate something more on a nationwide or a regional, that might be a situation where the VHL Alliance is the natural target to think about, having them be the administrative arm to create that sort of effort.
So funny you should mention that, Dr. Taikoti. The VHL Alliance does sponsor a program called the VHL Patient Consortium that is led by Dr. Eric Yonash at MD Anderson. and he partners with UPenn, he partners with BC, right north of you, your north of neighbor. Where's some of the other, Penn, MD Anderson, Vanderbilt. Yes, MGB as well. So, but this is clinical care centers that have come together and agreed to collaborate. And the VHL Alliance, he initiated this program using federal funding dollars to the tune of $5 million, right? But it lasted up until 2025. And they approached the VHL Alliance, and we were able to provide a bridge grant for this year while they are seeking that next level of funding, which will probably come from NIH. But your donations made that happen, right? So when you donate to the VHL Alliance and you restrict it for VHL research, that's how the Alliance and patients and families really make a difference in that space.
So just wanted to add for some context, we set up in Canada, or we are setting up in Canada, a pediatric renal tumor registry. We got a $200,000 grant to do that, and that's in a country where we already have an existing infrastructure for collecting data across the country on patients with cancer. There's only 16 centers that treat patients with cancer, so it's a lot easier to centralize that. That was still 200,000, and we are kind of getting to the edge of that in order to set it up, so to get an idea of that. I think the one thing I would just advocate for is there are a lot of organizations that advocate for, and reasonably, for the thing that they cover. So like VHL Alliance will obviously advocate for more VHL funding, and the Legal Committee Center Association is going to advocate for more legal funding. But the really important thing is that as a country, to keep the research level high and to do everything, we just need NIH funding. We need generic high NIH funding. And that is if I was going to say advocate for anything on the research side, it would be for that, to advocate for NIH funding so that research in general can be done, because a lot of what you're going to learn about VHL is going to originally come from research that has nothing to do with VHL, and then will be incorporated into that research. So I think, if there's any big threat right now, it's the fact that the pay lines between how many grants are funded is around 4%, which is very difficult to navigate.
And by the way, I would actually also argue the flip of that funding towards VHL research doesn't only impact VHL and VHL disease, but it actually has way bigger implications in the world. Right now, we only have one drug that's approved for VHL, but there's 8 other drugs that came out of VHL research that never got approved for VHL, but ended up getting approved for other cancers. So VHL research is at the core of a lot of research in general, which is why it's such an important thing to fund research into.
Just a quick comment about advocacy. I've had a lot of contact with Kidney Can, a kidney cancer advocacy group that operates nationwide. That's been very involved in advocacy, trying to support federal funding through DoD, which has disease-specific earmarking of money. So I think that approach of applying your efforts in the context of a group that could try and really, hone the message. But, having patients as part of that process and getting in front of your representatives, I think is really impactful. So I encourage people to look for those kind of opportunities.
And to do another plug, we have some information on our resource table. If you do want to become a patient advocate, we are happy to sign you up. So we are at the 11 o'clock point. I think it's time to take a break and take a stretch. So thank you very much, Dr. Chakoti, Dr. Raskin, Dr. Brzezinski. Thank you. Yes, and Vicki, thank you so much. We appreciate you being here today. Awesome. So I want to thank our, we'll do some introductions, but I want to thank our family members that are going to share their journey. Josh is going to ask some questions, and then we'll open it up for more questions and more sharing. The real connect part of our VHL Connect. One thing I did want to plug while I have your attention, in those folders, you'll see a couple of notes about some in-person events that are happening. The first being our VHL Alliance Walk. So we have a national fundraiser that we host the third weekend of May all across the country. So last year we had 30 teams. It starts at 10 a.m. Pacific time, 1 a.m. Eastern Standard Time. And at the same time, we will have dozens of families walking, raising awareness for VHL and raising funds for VHL and for research. It is so easy to start a team. If you and your friend want to go for a walk, start a team, really. And wear your VHL blue. So I would encourage you to create a VHL walk. The second thing is our annual family weekend. So every year we host a family-friendly event, which is very similar to a Connect, but bigger. And we're having that in conjunction with our young adult retreat. Both of them will be August 7, 8, 9 at UCLA in Los Angeles. So more to come on that. We're going to be spending a lot more time on the West Coast, considering the data that we're going to have. So I would encourage everyone to consider making their way down to Southern California. That should be really good for them. So with that, I'll hand it over to Josh.
Thank you. So this will be the patient caregiver portion of the agenda. I just want to invite our panelists, Mike Heffernan, Tricia Heffernan, and Peter Baki. Maybe if we could just go down and introduce yourself and tell a little bit about your story and mention VHL.
Sure. So thank you for being here. First of all, I want to thank Josh, you, and Janet for being here to do this event. We really need a VHL focus area in this. Thank you in the Northwest. So thank you for being here. Thank you to our earlier panel as well. It was really powerful to hear from you all, and thank you for organizing this event. So my background, so I work at this place. This is our headquarters, and our journey with VHL started 3 years ago. Our son Owen, who was 20 at the time, was diagnosed with a brain tumor, and he had to have emergency surgery to remove the brain tumor. And through that process, we learned more about his condition and that he was maybe predisposed to VHL. So we learned that over the course of a very challenging time in the hospital, and he is a de novo case, so it's not something we were familiar with. So that was our journey, and it's been 3 years and a lot of learning and a lot of growing. I was thinking about this event today, just how different our life is today than it was on that day 3 years ago, and so I'm happy to talk about that journey through this.
I'm Tricia, I'm Mike's wife.
I'm Peter. I'm a patient. I have VHL. I'm from the DC area originally. I'm married to the woman right there in the suit. And we moved back out to here where Miss is from last year. I am a public high school biology teacher by training, and I was diagnosed, I'm a de novo case as well. I was diagnosed at 23, I'm 39, so it's been about 15 years knowing that I have VHL.
VHL diagnosis is a massive shift in reality. Can you describe what those early days felt like and what initially helped you to ground yourself?
So, many people in this room have VHL. It's an incredibly kind of unmooring event. It's scary. You don't really know what's going on. You never heard of it before. We never heard of it. And candidly, we did not get much information at the time from our care team because they were not familiar with managing this. And so those first, stretch in the hospital is very unsettling. It's very scary. You're kind of trying to find firm ground is kind of the way I describe it. And you want to learn. You shift into learning mode. And so we spent a lot of time in the hospital. I did on my phone trying to understand what this meant, what it looked like. It was actually in the hospital where I came across the Belzutifan study. And so I actually learned about just scrolling my phone that was a medication up there that was available for this. So it's I think one of the things we could get much better at as a community in this is helping people understand this journey better. We thought we had to do a lot of our own discovery, and learning to get there. And I think it's exciting to hear about the earlier panel, how we're creating these connections between oncology and other groups to help patients understand this better. Because I think sometimes with the understanding, it's easier to manage and figure out what you can do with the path forward. And just getting to that baseline was a real journey. And once we got past the baseline, then I felt we shifted from kind of reactive to more proactive mode, which is a very empowering spot to be.
Yeah, I agree with a lot of what you said. I was trying to take myself back to when that happened. I was in Maine. Can I do the full story or? Sure. All right. So I was healthy, I was a college athlete, and it was my first job after college. I was doing outdoor education, so I was basically leading middle schoolers in the woods, and I was out on one of those week-long camping things, and I had symptoms of jaundice, and I was having these symptoms while I was out there, but I just continued, wasn't feeling well. When I got back off the course, I went to the ER, and so it went from, oh, I'm feeling ill, like, never had jaundice, to you go through this progression. Well, maybe it's, what they say, viral hepatitis. So I'm like, oh, I go home, I'm like, oh, I have viral hepatitis. And then you get a call, it's like, well, maybe you should come back in, because they had done just precautionary imaging. And that's when, like, the whole room starts to spin. And I think it's difficult because it's a steep learning curve of the disease, but you're also sick at that time. And it's also about you. And so what's spinning and what the learning curve is not just a complicated disease, but your whole picture of the future, your whole identity, self-concept. And so many things happen that even someone who I studied biology, went to college, I studied it, and it's still, like, I'm scrolling through my phone and trying to read every possible thing, but you imagine if it's someone who has scientific experience, it's still like, it took a lot of repetition, a while to really wrap my head around it for the general population. And as an educator, you understand, like, how much repetition, or how difficult it is to actually learn something without a lot of misconceptions. I had plenty of misconceptions, so it's really a challenging time, and it's an important time to figure out how to reach somebody and educate. It's not straightforward. You can't just hand someone a packet and be like, we got a great resource for you. Like, that's not the end of the day. It's not the end of the learning.
You also got to be careful a little bit about, there's a lot of rabbit holes you can go down when you start researching online. And so a lot of the stuff I found initially were studies from 20, 30 years ago, where the patient stories and the outcomes were just so different. That's the first thing you see. So I think it's important to be educated and be your own self-advocate, but you also got to be really careful about what you're reading, because some of the stuff is no longer really impactful today. And so I think as it gets back into, if we can equip people with this diagnosis sooner and better with really what that life experience can be, and how you can live with it, then I think it'd be a really powerful transition.
Was there a specific turning point early on where you felt you shifted from simply surviving this news to actively managing the condition?
So, one of the challenges with this condition, this disease that we talk about, is it's multidisciplinary. It covers all, whether it's manifested in the brain, but it has effect on the eyes, the spine, other parts of your body. And so it's a lot to figure out kind of how to navigate that health system and what that means and how you get educated on that. We're lucky that we live in the Northwest, that there's such great care here. But we actually, I didn't really know this existed, but we got a patient advocate who was connected to us through a family member who had gone through cancer. And this was a very seasoned individual in the 70s who was very well versed in the U.S. medical system. And he just kind of knew where to go for different items. And so we got connected to him. He was amazing. He did it pro bono. This is what he does. He basically has a foundation that he takes charitable donations and he helps people navigate this. But he connected us with initially Stanford and then MD Anderson, and he connected us with the right spinal doctor at Columbia. So he was able to kind of help us figure out how to navigate a very complicated system. And he would come to the appointments with us, he would help us ask the questions, he would decipher what we heard. And so we ended up making a big donation to this charity because that's kind of, he was really life-changing for us in terms of being able to kind of navigate the system. And so, but I think if you didn't know that kind of service and those kind of people existed, it would just be daunting to try to figure it out. So that to us was really the turning point, was getting somebody who could help us figure out how to navigate it and not just kind of react to it.
Add quickly to that, I think it was also, we really established a care team. And as Mike said, we got going to Andy Anderson to find a specialist who was well-versed in those to kind of guide us on starting up with a young person. And I think once we had the care team in place, diagnosis was confirmed, and we didn't have our specialist, that it really kind of gave us that feeling that things settled and kind of seeing how these are belt and which direction was going. I think that was, it was probably a solid year.
Yeah, I think for me, it took multiple years. I think because of the time in life, at the beginning, it's like, just started, I was like, I don't know, this job. And then, no, your job. Because I didn't say what I actually had besides VHL. So I had a lot of tumors on my adrenal glands. That wasn't even causing the initial jaundice. So I had a lot of POs on my adrenals. And then I had pancreatic tumors, which that's what was causing the presenting symptoms, squeezing the bile duct. So I had, right off the bat, diagnosis. The next month, I had bilateral adrenalectomy, which is intense surgery. It's an anesthesiologist's dream because of the epinephrine. And then 3 months later, I had a Whipple, which is, the long name is a pancreatic duodenectomy, which is one of the more intense surgeries. And so I was out, I left my job. So it was really, I was overwhelmed. I wasn't even like barely surviving for the first year because I was getting the surgeries and then recovering from the surgeries and then figuring out what I was going to do next. It wasn't really until probably 3-4 years later where I did get established, like got back in a job, found I was in a consistent place, wasn't bouncing around to where I could start to manage and not feel like I was just surviving. So it's the time frame of understanding what's going on, but also just like surviving. So again, that whole idea of being the initial phase of being disoriented, it takes a long time. It took a long time for me. So it was definitely between like 2 and 5 years to feel like I was like understanding it and managing it well.
What's one vital piece of information that you wish your medical team had shared with you on day one? Is that funny? Or just one vital piece of information? Yeah.
Well, the first thing that came to mind was, and we were talking about this last night, was don't get a brain and full spine MRI in one go. It's too long, you're gonna cry. I cry. Vital. I honestly think, like, speaking back to what you were saying about going down rabbit holes, because I definitely did that as well. I'm not a WebMD researcher, but I did a lot of online self-research, and you'd like to think you know, and you're going to be wrong, because there's people who devote their whole lives to get this detailed information. But I remember my surgeon saying, he was trying to be helpful. He was like, it's going to be a new normal after the surgeries or with taking medication, because I take hydrocortisone 3 times a day as a vital medicine because I don't have adrenal glands. And in a sense that helped. Like, it's going to be a new normal. You're going to be okay. Like, that's what he's trying to say. But that didn't fully make me feel great. I think what it comes down to is you got to take it one day at a time. Like, that to me, like, really is the most helpful because projecting the future, right? Like, everything's catastrophizing, but regardless, even if you're recalibrating in a more healthy way, you're still like looking too far out. And so it's good advice for anybody, but like take it one day at a time, I think would be the thing I wish they would have told me.
The thing I would tell anybody is getting this diagnosis for the first time is you can live and thrive with this condition. You know, you live with it and live your life. You know, it's very overwhelming when you a loved one, in this case our son, you know, you hear you go from normal day living to suddenly, you know, a brain tumor to surgery 2 days later, and that's a lot to process for anybody. But I think what really landed it for me is one of the VHL parent support group calls. They had both parents of patients and patients on there, and I remember, I think maybe it was a parent that said this, or maybe it was a patient, said that the way they think about it is they put it in the box, they live their life, and then when they need to deal with it, they take it out of the box and whatever that is. It's like, okay, time to get a scan, I take it out of the box, I think about it, I go do it, put it back in the box, and then go live life. And so that, we did not see that path when we first got the diagnosis. We didn't know what this looked like. And so that'd be one thing that I would say is, I mean, people have all kinds of conditions in life, and this is one you can live with and thrive, and you should do that.
We talked a little bit earlier about scanxiety from a parent's point of view, but also from somebody with VHL's point of view. How have you dealt with scanxiety, and do you have any strategies that you think would be helpful to share with others?
I guess I'd say that I try to look at it through the lens of, I mean, information is powerful. In this case, I think we're lucky to basically be in an environment like the Northwest where you can get ready access to scans, and you can, with information you can action. That's kind of the way I think about it. So scanxiety, I understand, because I can almost envision, like, back before, you know, therapists like belzutifan, what that must have been like, because I think it must have been like, what's my progression been and what's new, and without really kind of more of a more positive outlook on it. And so I tend to think of it more as we're lucky to basically be in a situation where we can get this information, and with information we can act accordingly. And so yes, there's that feeling like, okay, something new going to be there, but we also, it's information that we can take action on. And one of the things, you know, with VHL is these tumors tend to grow very slowly, so you can see them early, and then you can figure out what that journey is going to look like if there's something new. So I tend to look at it through the lens of empowerment and learning, and less from, you know, this is, you know, earth shattering if there's something new we have to think through.
Yeah, scanxiety is real. I mean, definitely experienced it. So I think that in itself is helpful to sort of accept it, that you're not trying to get rid of it, and to be kind to yourself. There are plenty of strategies. I think I think compartmentalization and distraction aren't. Yeah, it's not. Those are good and fine strategies. But I think, yeah, not just realizing that it's there, and you have worries for good reason sometimes. And so that's where the support system comes in. I think Vicky said, I think Vicky was mentioning mindfulness. When I first was diagnosed, I would have had no understanding of mindfulness or mindfulness practice. But I remember almost like developing the practice in the MRI machine. So it's definitely good to not have that be the place that you're trying to meditate for the first time. I was like, I'm a monk now after 1 hour. But I do think if you haven't and you go into these scans, that I really do think the mindfulness practice is super helpful for that part of the anxiety. I think I more experienced anxiety with the results, like a lot of other people do. So there's multiple factors, right, of the anxiety. Like there's the flight, you know, the airplane anxiety, but there's also like, what are you going to get as your results? So I think those are two, and that's why leading up to it might feel like sort of nebulous anxiety, because multiple things happening that you might be worried or anxious about. So I think, yeah, just different strategies. Everyone's going to be different, but it's a real thing.
This question is for Peter. Obviously, it was very intense when you were first diagnosed. How has your approach changed towards managing your care and preparing for surgery and whatever from your first situation when you were diagnosed?
You said, how has it changed? I think the anxiety has lessened, like anything. The more you do it, the more it becomes like routine. And I will say with the medicine, like you were mentioning, you're like, what is it? You and your son don't know what it's like before Belzutifan. So really, it does change. I feel like there's less of almost like a knife hanging over my head every time I go because I sort of have that. It just feels like a less dramatic or intense disease when I'm also taking the medicine. And yeah, I don't know how it changed. I mean, when you grow up, you just manage things a little bit better. I guess I could talk about this now. As there was periods of my life, and I do this with the dentist. So I joke with people that I'm like, I see so many doctors, I don't go to the dentist, which is, it makes no sense, right? But it's the easiest one, the most, it's very important one to do. But I'm overloaded with medical, so but there was for a while where I would miss appointments and put it and just not schedule it. So they're like 5-year gap where you haven't, done the imaging, and that happened probably multiple times. So I think with repetition, with maturity, with support, try to be more consistent. So I think that's one big change as well. Just like you got to do it and getting better at being consistent. So that's me, and it's also being having a care team and having the support.
So this next question is a little bit heavy, but VHL is inherently a family disease, not just because it's a hereditary disease, but because it literally affects everybody in the family, whether they actually have the VHL or not. And I guess this is more for you guys, as parents, how have you navigated these complex, complicated, and emotionally intense conversations with family regarding things like genetics, family planning, planning in general, things like that?
Keep saying it to me. Well, the first thing we learned we had to do was we all had to get tested when no one was diagnosed. And so we have 2 other kids, all right in the middle. So Christian and I got tested. Our other kids got tested. So you have to have that conversation initially. And all of our kids at the time were sub 23. And our youngest was about to head off to college. And so we had this moment where, okay, before we can keep living life the way we're living it, we need to kind of understand what this means for all of us and our family. So that was the first thing we had to do, is have that conversation among all of us. I'm blessed that I come from a very large family. I'm the youngest of 7 kids. My sister's here too, by the way. And so one of the things that we also leaned on was, and I'm also lucky that many of my siblings and their spouses have medical backgrounds, so thank you, Craig, as well. So we got a lot of, we're very transparent with our family about kind of what we were experiencing, and we had to learn a lot, and we needed help and guidance. And so you kind of find this balance between you want to be very transparent and honest with what's going on, but you get tired of talking about it too. And so you have to find this right balance of kind of what, how to manage that. People when you tell people that you're going through something like this, they naturally want to learn more and they care a lot. So you want to basically honor that interest and then want to care and support you. So that's kind of how we done it, I guess, just trying with transparency and also I just think that from a family dynamic standpoint, I mean, it definitely it was kind of a huge wave that came through our family and what that meant for all of us and their siblings and everything else, but you also realize that life can get back to normal, and so so you kind of figure out kind of the new normal here, and so that's kind of how we've done it, I guess.
So, a theme that comes up very, very often in the VHL community among parents, even parents who have a de novo child, so it wasn't hereditary, or between siblings where one sibling has VHL and the other doesn't. And this comes up all the time, is this sense of guilt. And it's a very heavy feeling. How have you addressed that? As parents, and also as a patient, how have you addressed any feelings of guilt, or have you had to navigate that at all, either within yourself or within your family? Right.
I don't know if I I try to describe guilt as the main emotion we felt. I think ours is more kind of worry and hope for the future there. I mean, maybe the one way I'd answer that is, I mean, we have friends who have, lost kids to cancer. We have friends who have, every family has something, right? And so I think part of it is, and I think you said this, Dr. Raskin, that, we're all kind of genetically wired individually here. So I think none of us are wired to be superhumans, and so we're all going to have something in our lives. And so I guess the way I think about it is, it's good to be aware and have knowledge when you have a condition like this, so you can manage it thoughtfully. But I don't know if anybody's feeling guilt about how they're biologically composed and what that means. That's a terrible place to be. So I say that's not the way to live a life. And so I would say, understand and know so you can basically get the best care of yourself and your family and everything else. But also, I would say don't live with kind of that guilt overhang, because it's something any of us can control. But what you can't control is kind of what you do from that point on in terms of informing family and doing the right things to be proactive where you can. So maybe not a great answer, but I think it's just kind of figuring out kind of how to recognize that this is our reality, and everyone has their own, and then how do we live with it the best way.
I don't have much to add to that. I do think I imagine in families where it is established, so both of our families have de novo cases, but if it runs over generations, there may be more of sibling dynamics. One person has it, one person doesn't. I will say maybe more a funny anecdote is, I don't know about her guilt level, but my sister, after I was diagnosed and she spent a lot of time in the hospital with me, she became a nurse. So she decided maybe that was her guilt talking. She's like, I'm healthy, I'll just hillbilly. No, but yeah. No, I agree. Guilt is not a super practical thing to carry for a long time.
There is this positive. So Owen's younger sister, now she's a junior at university. She has decided she wants to be a computational biologist and focus with the study on kind of how AI is going to transform medications and everything else. And so she has an interest in genetics. So there's these positives for this as well in terms of how it influences the rest of the family.
Which is a great segue to my final question before we open up for the last few minutes questions from the audience. What, if anything, has been the most surprising silver lining or positive growth to come out of your VHL journeys?
We should both answer this one, but I would say that to me it's not surprising because Owen is a strong and smart kid. But the silver lining has been his strength and resilience in this whole thing. The way he has kind of gone through this journey, the way he has stepped up in terms of understanding how to live his life fully. And again, I'm not surprised, but I'm incredibly proud of what that means. And I'm going to cry.
We talked about this before because I will cry. This is why he's doing the talking, but I just to reiterate what Mike just said, was watching the courage and resilience and strength that a young person that must have one place to see that's where they have to challenge. And the way the rest of the family kind of stepped in and provided support in every way. So, we feel very blessed for all of those things. Sorry.
So the first place where I got care after being in Maine was Johns Hopkins University in Baltimore. And I remember going in, I've never really been in a hospital. And I just remember the feeling of like, all these people are not well. And it was very impactful. So I think what came to mind when you asked the question was, I think it's made me more empathetic. A bunch of people have mentioned that, like, so many people, you realize it's not just me that has like this condition. There's so many people who have chronic disease or who are going through really intense acute disease at any moment. So just this whole idea, and this was only further reinforced being a teacher. It's like people are going through it every day, and we pass them on the street, you don't necessarily know. And so for me, I think that's been the most impactful part. course, there's interpersonal growth with caring yourself, but it's really like opened my eyes to how many different things people are carrying, whether that's physical, medical, or emotional. So that's fine.
I think we are ready.
Or anything to share. This is really the opportunity for you to share your journey. We have about 15 minutes, but your journey can resonate with somebody else and maybe help somebody else.
Hi, everyone. I'll share my journey. It actually, I'm somewhat unique. It started when I was 7. So I was introduced to VHL at the age of 7, and my father was remarkably diagnosed correctly with VHL at Lancaster General Hospital in Pennsylvania. I think what we sometimes don't talk about is we're talking about a de novo, but my entire family had VHL, including myself. And, do the math, I was 7. It was at a time in the 60s where my mother, who was the odd woman out, she didn't have VHL, and she became not only the caregiver, but also the breadwinner. And the dysfunction it brings to the family dynamic is challenging. So, and also there wasn't resources then. There wasn't DNA testing. There wasn't the social workers. And so we've come a long ways. We have so many tremendous resources to be thankful for. And I would agree with you, Peter. I actually would say I was officially diagnosed when I went to the NIH. And I was part of that research for 32 years. But even so, I am always learning something new. And my good friend here, Diana, she has some remarkable words of wisdom that she produces on YouTube videos that's out there. I was first encouraged to go on Belsufan because of Diana. So sometimes you need that little nudge. And so the power of each other and collaboration, I cannot say enough how that is an amazing resource, each of us. I actually ended up going to the NIH because initially I was in my 30s and I had 7 hearing loss. I went to bed, I could hear, got up the next day and I couldn't hear, and it was because I had bilateral and no lymphatic sac tumors. And I had a VHL patient who gave me a nudge. And her name was Peggy Marshall, and she was actually the co-founder along with Joyce Grant for the VHL Family Alliance. But she said, Alice, maybe you have Meniere's disease, but maybe you don't. Why don't you call Dr. Savar at the NIH? And the rest is history. And at the time, just like Peter, I felt, I just stopped. I felt like somebody was kicking me in the stomach because I thought, I'm the one in the family that didn't have VHL. And but I've often taken the attitude, it's what I have, it's not who I am. And I'm going to pass this to Diana. I'm putting her on the spot because she has always been someone that I have looked to. So.
Hi, my name's Diana, and I got diagnosed with VHL 23 years ago, and it was because I had a headache. After 3 weeks with the headache, they scanned and found the brain. I was diagnosed with VHL the first day that I was in the hospital, just over October. So I have 3 kids. 2 are adopted, one's biological. My biological son has VHL also. And so one of the silver linings for me has been watching his siblings step up to support him while he's going through everything. And then that, if you could tell yourself something, if I could talk to myself at your age, I would say, make sure you check in with him once a year about his screenings his entire life. I lessened what I was doing about 10 years into adulthood, and he skipped his screenings the entire pandemic. So, do check it. Just make them lie to you. Yeah. I really like that one.
I'm not gonna lie. I think it makes sense because I was talking about 2 to 5 years where it was a little bit overwhelming. I didn't want to meet anybody. I knew about VHLA and my mom was involved and I didn't want to be involved. And I think that's because I was going through that process. But I do remember once I was ready to get involved, I was definitely still cajoled by my mother. But once you get that first interaction and start hearing yourself, oh, like the resonance, it's powerful, even if you didn't think you needed it, or even if you didn't think it would be helpful. So I just remember being kind of pleasantly surprised with the first interaction. And I've been loosely involved with VHLA since, and I have my first friend who has a VHL. He's actually on the board. So, and he was connected, we connected through VHLA. And so that's cool. I mean, so now it's like, it's not just some person who, we can compare notes. It's a person who's going through similar things that I would call a friend. So I think it's really powerful. And but I just wanted to say that process, it hasn't been like that from the beginning.
We don't have a lot of experience with this because actually Peter is the first person that we've met. That was last night. We don't have a lot of life experience to draw on, but we are definitely looking forward to being able to attend event.
we didn't tell you this last night, Peter, but it was, first of all, good to meet you last night, but it's also really great to meet your wife and daughter too. And I think, seeing some of your point in life, starting a family and that kind of thing was very powerful for us to see. So that was great. And I love what you said. One thing I want to double down on, because it's something I thought about and I heard when I was diagnosed this, which is, I think when you have VHL, it's part of your life, but it doesn't define your life. I think that's kind of something you should take away. It doesn't have to define your life. So.
We have a few more minutes. Anyone else feel led to share? All right. Yes.
Mike, you're with the song?
Yeah.
Can you give an elevator pitch as to what
we do?
does? Yeah.
Oh, sure. That's a segue. So we're a global consulting firm. This is our headquarters in Seattle. We operate out of, we have 10,000 team members across 12 countries and 50 cities. Our focus is, kind of what we do is sort of technology and strategy consulting, but I think our why is more interesting. It's been our why for decades. Our why is kind of a corny mantra, but I like it. Really why we do what we do is we want to help individuals and organizations, one, dream faster, or dream bigger, sorry, move faster, and then build better tomorrows. That's what we say. And so we do a lot of work in the life sciences space in the Northwest and otherwise. And we try to live that. I was telling Janet about one of the things we're working on right now is we're doing some pro bono work with something that's new. It's called the Cancer AI Alliance. And it was something that was actually came out of the Hutch, was the birthplace of it. But basically what it is some of our technology partners, in particular AWS, Google, and Microsoft, came to us and the Allen Institute for AI and said we want to basically figure out how to share learning more effectively across cancer centers. And so I wrote the names of I won't get them all remembered, but it's the Hutch, it's Johns Hopkins, it's Sloan Kettering, it's a few other cancer centers. And the vision was to leverage partner technology like AWS as a platform. And could you figure out a way to create agentic workflows using AI agents? AI agents are basically workflows that operate on their own. And basically the idea would be they would be able to go into the challenge with this kind of information is protecting patient privacy is incredibly important. And so the idea was, could you go into each of these cancer centers and anonymize the data from the treatments and the efficacies and the outcomes and keep all that information resident within that cancer center, but surface up the learnings and insights to a collective database built in Snowflake. And so we're early stage on this. It's being run by out of our Seattle office here, and but the initial findings are super powerful because what you start to find is start to see one thing the AI is really good at is looking at large quantities of data and spotting patterns. And so we're beginning to spot patterns of different treatments and efficacy thereof. So that's an example of the kind of work we like to do. We've done some other work with the American Cancer Society in training AI how to spot cancers and breast cancers, and creating a very effective way to do that at scale. So that's the kind of stuff that we do. That's kind of what we do. Yeah.
So that officially concludes our VHL Connect. I wanted to thank our patient panel again for being open. I want to thank everyone here for joining us. Thank you again to Slalom. Thank you. Big round of applause for Marta, who handled the logistics of stuff. Thank you, Marta. And of course, again, to our sponsors, Merck Pharmaceuticals and Ambry Genetics. I do want to invite everyone. We have lunch available for everybody. There are box lunches. I would encourage, it's going to be over in the town hall, town center. I encourage you, grab a box lunch and get to know one another. We have all the time in the world to connect. That's what this is about, is for you to learn from one another. If you feel like you need to take the dash and dine and dash, grab and go, that is fine too. But I want to thank you again for coming. Encourage you to keep the momentum going. You are what will grow this community in the Pacific Northwest and in Seattle in particular. And thank you for Tricia, who does serve as a VHL ambassador. It's a program that we're looking to grow. And that's, with our relationships with Fred Hutch, our relationships with UW, with Seattle Children's, and with you is what will increase and optimize health outcomes for all VHL families in Seattle and the Pacific Northwest. So thank you. Thank you for that. Yeah.
Just real quick, my role at the VHL Alliance is the Director of Health, so I work with patients and families and clinicians, to make sure everyone's getting the care they need, has the information they need, and whatever support resources. My business card is on the table, on the resource table outside, has all my contact information. Please take it or write down my information, and if you need anything, have any questions, need to be connected to somebody, want to meet another patient or a family, anything at all, please don't hesitate to reach out. That's what we're here for. So thank you again.